everybody. Thanks so much for coming to what is going to be an excellent session. This session is entitled From Online to Door-to-Door, Expanding Access to HIV Self-Testing. So welcome. We've got a really wonderful panel of speakers that will be bringing us around the world with the developments on self-testing. A lot of really exciting work has already been shared. Some commitments to scaling up self-testing have been made. So we have a lot of lessons to learn about the right service delivery models and what experiences we're learning from the field. So we have a set of presentations that are rapid. So they will be about 5-minute presentations. We'll pause for maybe one quick clarifying question after each, and then we'll have a group discussion at the very end. So if you have a question, please be ready to stand. There's microphones that are numbered to the sides, and that's what we'll use. So we'll have to move quickly so we can get through all of our speakers and make the most of learning. So without further ado, I want to introduce our first speaker. This is Karen Champenois from France. She has been working for 10 years on observational and interventional research in the field of HIV testing strategies, HIV and STI prevention, and sexual health for men who have sex with men. Thank you, Karen.
Thank you. Good morning, everybody. I would like to thank the organization for letting me the opportunity to present this work on HIV self-test in French pharmacies. The HIV self-test came onto the market in France in September 2015 with the aim of increase HIV testing uptake and frequency of HIV testing of key population. The objective of the present study performed in the year following commercialization was to describe pharmacists' experience and pharmacists' point of view with regard to dispensing self-test in their pharmacy. So the method from January 2016 to January 2017, 23 interviews were performed with 28 pharmacists in 4 French regions, 3 regions with high HIV prevalence, that is the island of Guadeloupe and French Guiana, that is two French overseas departments close to America, Paris suburbs with large migrant community from sub-Saharan Africa, the Marais, the biggest gay neighborhood in central Paris, and 1 region with a low HIV prevalence in northern France, the city of Lille and its surrounding area. And we perform a thematic analysis. So the experience of pharmacies with regard to selling HIV self-tests showed that key population were interested in self-testing and asked for self-tests in local pharmacy. Clients were mainly MSM and young people and a few people from sub-Saharan Africa. However, a significant barrier remains. First, about the confidentiality. I will be talking about it just after. The high price of self-tests that from 20-25 euros in Paris up to 40 euros in pharmacies in the West Indies. And also the pharmacists have to make sure that clients understood the window period. Several pharmacists report that clients asking for the self-test in an emergency situation, like a morning after pill. Most pharmacists interview was very enthusiastic with playing a real public health role in HIV prevention, and so the HIV self-test like a good way of contributing. A significant number of pharmacists had made specific efforts. They train themselves and their team about HIV testing and HIV support, and they keep the price of HIV self-test as low as possible, up to tell it at cost price for some of it. Pharmacists report major issues and concerns. First, financial issues, particularly with regard to unsold expired self-tests. There was an initial campaign of communication in 2015 when the HIV self-tests were launched, and there has been no further communication afterwards. Pharmacies have not sold as many tests as expected. In most cases, the layout of a pharmacy limits the confidentiality and limits consequently the possibility of discrete exchange between clients and pharmacists, and for pharmacists to provide information and support. And many self-test clients want maximum discretion. Pharmacists report that it was sometimes difficult to communicate and give clients information about how doing the test, and in particular about the implication of the window period. For example, these pharmacists will report that some clients said, yes, I know, just to go very quickly. So as conclusion, we can say that the study highlights the fact that pharmacists can play and want to play a significant role with regard to HIV prevention and service testing. Their proximity and the long opening hour make them easily accessible for individuals who have questions about HIV or care in general. And pharmacy are more accessible than existing testing center. Further public campaign and communication are needed to promote HIV self-test and also support pharmacists in playing a potentially significant role in HIV prevention and screening. So the next step is the point of view of user about HIV self-test access, and the analysis is currently ongoing. I would like to thank all pharmacists who participated in the study and for funding the ANRS et Santé Publique France. And thank you for listening.
Thank you so much. If there's any quick clarifying questions, we can take one. Okay, we've got one coming. Please introduce yourself and where you're from when you're asking your questions.
My name is Rebecca Guy from the Kirby Institute, so thank you for the talk. And it's great to hear about programmatic use of self-testing in France. I just wanted to ask you a little bit about the test itself and the requirement in France for provision of information. So when people come to the pharmacy to buy the self-test, is there any requirement for a video or information that they may need to see or to hear to be able to use the test? Because I think from what you're saying here, people really just want to pick up the test. But there's a number of studies which show, depending on what type of test it is, that videos or good information can be quite helpful to make sure people do the test correctly.
Yes, the HIV self-test have the French one. There is an instruction leaflet with a lot of pictures, and I don't think you need to read well French. You can do it with picture, and there is a link to a website with video on the website.
Excellent. Thank you so much, Karen. I'd like to introduce Peach Indra-Vood from the United Kingdom. She's our third speaker and a research fellow in the Department of Global Health and Development at the London School of Hygiene and Tropical Medicine. Thanks so much.
Okay, great. Thanks. I'm going to be presenting on a study we recently completed this year on providing community-based HIV self-testing kits in rural Malawi, evaluated using a cluster randomized trial design. So in Malawi, about a quarter of people with HIV still do not know their HIV status, with testing the biggest gap along the HIV treatment cascade. This coverage is disproportionately low in rural populations and then also as well in men and adolescents. So against this background, we conducted a 2-arm cluster randomized trial to evaluate whether providing self-testing kits at community level could improve testing in populations that are underserved by facility-based testing. We worked overall in 4 districts in southern Malawi, and we randomized 22 rural government health facilities to either community-based self-testing or the standard of care. So as part of the intervention, we had resident community-based distribution agents, or what we called CBDAs, provide door-to-door delivery of oral fluid self-testing kits. So these were provided in the clinic catchment areas for a period of 12 to 17 months. The CBDAs also provided optional post-test support and assisted referral to confirmatory testing and ART services if they requested it. Our primary outcome for the trial is self-reported HIV testing in the last 12 months. We also looked at self-reported lifetime HIV testing, and we measured these endpoints through population-based surveys in our selected evaluation villages. And then our secondary outcome was population-level uptake of ART, which was measured through clinic registers, and it evaluated a population of around 100,000 adults. So I'm going to present in this short presentation the results of our primary and secondary outcomes. So for HIV testing, our analysis adjusted for individual and baseline cluster level imbalance. And then for the ART outcome, we adjusted for ART initiations in the 12 months prior to cluster enrollment. Our main results indicate that there was an effect of the intervention on increased HIV testing. In the intervention arm, 68.1% of our sample of about 4,500 reported that they recently tested versus 48.4% in the standard of care arm with an adjusted risk ratio of 1.33. We also conducted a subgroup analysis and found that there were more pronounced differences by arms in adolescents, men, and the highest income strata. But when looking at the intervention effects, the interaction effects, they didn't vary significantly by age, sex, or wealth status. When looking at HIV testing, ever testing, this was also higher in the self-testing arm with 86.9% ever testing compared to 78.5% in the standard of care and an adjusted risk ratio of 1.08. And I don't present it here, but there were similar differences in terms of age and sex for our subgroup analysis of lifetime testing. In terms of population level uptake of ART, we didn't find any measurable effect of the intervention. So in terms of the fidelity of the intervention, our program indicated that 157 CBDAs delivered over 200,000 self-testing kits across a 17-month period. The number of kits distributed to women and men were similar across the implementation period. When looking at age groups, a higher number of kits were given to young people aged 16 to 24 years old. When we look at our household survey data, uptake of self-testing was around 42.5% in the self-testing arm, and it was 8.3% in the standard of care arm due to some other self-testing program that came in. So for social harms, they were quite low. We recorded 3 cases of social harms in the evaluation villages through these monitoring, community-based monitoring systems that we set up. The most severe cases involved marriage breakups that were eventually reconciled. In conclusion, our community-based self-testing program resulted in an improvement in knowledge of status in hard-to-reach rural populations, including in men and adolescents, and this overall resulted in minimal social harms. However, we did not find any measurable effect on ART uptake at population level. And to thank my colleagues at STAR. Thanks.
So we have time for one clarifying question. Okay, thank you.
John Stover from Avenir Health. So you said you distributed 220,000 self-tests. Are you able to work out how many were actually used?
Not through our program data. No, we requested for HIV self-testing kits to be returned, but that is more a reflection of return rate. But in our household survey, we were trying to track the percentage of people exposed to self-testing versus the people who actually self-test. So I think that that breakdown was around 50% of people said that they had received a self-test kit and 40% said they had self-tested. So I guess maybe about 80% usage.
Excellent. Thank you so much. So I'd like to invite Kawango Agat, who's our next speaker from Kenya. Kawango is a Kenyan research scientist. She obtained her PhD from the University of Washington as the director of the Impact Research and Development Organization in Kenya, and she'll be talking to us today about couples and partners. Excited to hear from her.
Right. Good afternoon, I think. So thanks for coming for this. I'm going to talk about secondary distribution of HIV self-test to promote testing of partners and of adolescent girls and young women. And this is a subgroup analysis of an RCT that we completed about a year and a half ago. As a matter of background, we know right now we have about 2 billion adolescents, half of them 15 to 24, the other half is 10 to 14. And since the epidemic started, about 100 million have been added to this. And we are having or experiencing about over 1,000 infections among adolescent girls and young women every single day. And of all the infections in adolescents, 3/4 are coming from adolescent girls and young women, and only 1/4 is coming from adolescent boys and young men. And where we begin to see the age difference is actually in 15 to 24. The other age categories, there's not much difference. And so what we did was to analyze or do a subgroup analysis of women in an RCT that we had done based in Kisumu in the western part of Kenya, where HIV prevalence is about 20% in the general population. Participants were women seeking antenatal care as well as postpartum care in 3 government health facilities within the town. And we are randomly assigned half to half to intervention and control. In the intervention, we offered 2 test kits to the women and trained them on how to use it. We asked them to explain back so that we were clear that they understood it well enough to be able to explain to somebody else, and encourage them to test together as a partner, but as a couple, but those that were not able to just give their partners to test at a time of their convenience. And in the comparison, we gave the referral coupon where the front was encouraging couple testing, but at the back we had information about the importance of testing, couple testing, and where they could reach us in case of social harm, questions, and so on. And we then followed up at 3 months. The key results, we enrolled about 600, just about 600 women. About 61% of them were in this age category that I'm presenting on. And 179 and 188 had been randomized to HIV self-testing and comparison group, respectively. And we followed up about 95% of these young women. 7 participants reported yes to, we had 7 questions on GBV, and on examination, none of them was related to study participation during this period. So the main outcome, we recorded about 56% of women in the comparison group reported partner testing compared to about 92%, which gave us a difference of 37%, which was statistically significant. Again, we had multiple secondary outcomes. The main one was couple testing. So there was the partner testing, which was the key one, but there was also the couple testing. How many of them were able to convince their partners not just to test, but to test together as a couple? And we have 38% reported testing together as a couple compared to about 78%. That gives us a difference of 40%, again, statistically significant. And in conclusion, the provision of multiple self-tests to young women was effective in increasing both partner and couple testing. And there was no IPV related to study participation or the use of self-testing by the partners. Our findings suggest that HIV self-testing can actually play a prominent role in facilitating testing among male partners of adolescent girls. As we know right now, we've had a lot of focus on adolescent girls and young women leaving out their partners, but at least right now there's a lot of focus on who is having sex with our girls, and do they know their status. And as countries scale up HIV self-testing, there's need for investigation investigation of the secondary distribution model to promote couple and partner testing among even younger women, probably going lower than 18. Ours was age 18 and above. And I just want to thank all study participants and everybody who participated, but I just thought the blue one, I went to apply for a visa and I was told that I don't need to pay because I was coming from the low and middle income country. So I was so excited I went back with my money. And I think I just need to thank them. And for more information and all the details, the poster is near the Emerald Room. Come for that right after this. Thank you.
So I think there's a question. Oh, yes, please go ahead.
Thank you so much. I'm Ali from UCSF. My question is that did you see a difference when you look at the results by the type of the partners, like different, like immediate partner, like a client or those kind of things? Have you looked at the type of the partners?
Right now is when we're doing a follow-on study to look at actually type of partners. For this other one was the primary partner. So we asked them to give whoever they consider their main or their primary partner, because we only gave them 2.
Oh.
Yeah, but right now we are actually doing a study where, earlier on we had done a study where we gave 5, but those were partners of sex workers. And we were able to then assess which kind of partners are they giving and what is the sexual decision-making following testing together as a couple. When you test both positive, what decision do you make? Do you stop having sex? Do you use a condom if you're not planning to do? And so on and so forth. So we did that, and there was an indication of actually safer sexual behavior with casual partners following self-testing as a couple. And so that is the concept that we are now exploring in a major study. Yeah.
Thank you.
Thanks. Okay. Excellent. Thank you, Kuango. Just to our next speaker will be Mark Q. Page, coming from the United States. Mark Q. Page is a program manager at Project Achieve at the New York Blood Center and HIV Prevention Research Center in New York City in the U.S. Thank you, Mark.
Good morning. Okay, so now. Good morning again. I'm sorry. HIV testing among young black men who have sex with men and transgender women in New York City. Lessons learned and trust and our study. In the United States, MSMs make up 70% of new HIV diagnosed within the year of 2014. HIV testing is a crucial gateway to HIV testing and prevention, including PrEP and PrEP. The CDC recommends that individuals at risk for HIV testing every 3 to 6 months. In 2015, young black MSMs constituted more new diagnoses than any other subgroup by race, ethnicity, age, or sex. MSMs are 7 times more likely to be unaware of their HIV infections as compared to other young MSMs. Increasing HIV testing among young black MSMs is crucial to reducing the disproportionate disease burden in the black community. Lessons learned and trust intervention. The trust intervention taught friends or buddy pairs of MSMs how to correctly self-test for HIV and how to support each other's commitment to consistent HIV testing. Why did young black MSMs agree to participate? Most trust participants entered the study in order to learn their HIV status and, if negative, how to remain HIV negative. Why did MSMs choose the friends they chose? To start, we asked participants why they came together and what made them choose each other for this project. How did having a friend present affect the experience of testing? During the process, a noticeable level of comfort permeated the environment due to the fact that participants were trusting with a family friend or with a friend or buddy. And from my experience with them, that was most important for them to have somebody there while they were being tested. Participants reported that HIV testing was less stressful because their friend was present during the testing and at the same time of receiving their test results back. A crucial part of the intervention was encouraging the friends to have open discussion of the nature and dynamics of their relationship or their friendship and how it affected the intervention content of testing. One of my key goals was to encourage the friends to share honestly about their sexual behavior and relationships within a safe environment to help build trust within the friendship. Now, the key mechanisms of action: knowledge, skills, and motivation. What we found is that most participants believe that HIV testing on a regular basis is a necessary tool in staying HIV negative. The skills, the hands-on method was crucial to learning how to operate the self-tests and increase the confidence participants needed to manage their own HIV testing, as well as help them to make healthy sexual choices while building trust and safety in their relationships. The motivation, trust. Participants almost always anticipated that the HIV knowledge and self-testing skills developed would motivate change in their future sexual behavior. Peer support. During the testing intervention with a friend was noted a novel and helpful. How are these test kits used on themselves? Although some participants articulated that they use a self-test with a sex partner prior to sex in order to reduce HIV risk. What I would like to please ask you to please look at this part here, because this is really important here, as well as everything else. But what's really important here is what do participants recall about trust? So after following them for a whole year, what we do, we have an exit interview, and some of them have been randomized and chosen to come back and meet with me. And in that process, we call it the exit interview. And during the exit interview, we ask the participants what stayed most with them throughout this year in trust while they've been in the project. And these are the words that they gave back to us. And what they said was that the fact that the fact that you guys are bringing people in as friends to learn how to self-test each other at home and outside of this whole, CBC or aspect that they're saying. So basically what they're saying is that we invite them to come in, they bring a friend with them, or they might bring a relative with them, and they test together. They receive their test results together, and because of that, there's a skill that's been developing, and they are also developing trust with that person that they're there to walk with and journey with throughout the year. Also, what's important is that they have said to us that trusting other people. Some of these young men have not trusted anyone, really. So now they find themselves trusting and they're learning skills. And while they're meeting with me for approximately 3 hours, I'm also imparting on them how to trust and developing skills of trust in the room with me.
I'm sorry, I'm going to have to ask you to wrap up.
Thank you. Okay. And since I've been, all right, this is the last one. So you guys are very respectful and trust you guys. I trust you guys with everything that I spoke to. And so that's basically what it is. It's that they're saying that they trust us. So thank you very much.
I think I'm just going to go to our next speaker. So I'll just introduce Andra Kitve. Andra is a doctoral degree in public health and epidemiology. In parallel to academic work that she's doing as a researcher and trainer, she also works with many NGOs working in the field of HIV in Latvia. Thanks, Andra.
Hello to everyone. And yeah, my name is And, and thank you for choosing our poster for this oral session, because it's a really great honor for me to be here. And yeah, I will present you the very preliminary results of our study. And yeah, the title is of the poster is Diagnostic Accuracy, Feasibility and Acceptability of HIV Oral Fluid Rapid Tests Among Hard-to-Reach Key Populations in Latvia. And we are the country with the highest infection rates in Europe. So I think the previous speaker from United States never had a question where it is. The country, I mean. That's why, but I got the question just a couple of minutes ago. So, yeah, Latvia is a small country, one of the Baltic states. The population is only 1.9 million, so we are a small country. And just some background information. Yeah, the first registered HIV case in Latvia was very quick after the discovery of the infection, so 1987. Yeah, the project I'm representing here, so we are working together with French and Belgian partners. And as you know, in the Western Europe, the epidemic is driven mainly by MSM. But our epidemics are, yeah, actually driven by people who inject drugs. From the very beginning, actually, from 90s. But since 2008, the main mode of transmission we are having now is heterosexual contacts. Yeah, and as I said, in the among the European Union countries, we are unfortunately on the first place if we are speaking about annual new diagnosis, which is 2.4 times higher as the average rate in European Union. And yeah, what's the problem? Okay, we have the highest rates, but we know that these cases are not all cases. Like the estimates are showing that our numbers the real numbers are twice higher even. And the second thing is that most of the cases, so we are diagnosing still our infection very late. And yeah, that's why the problem is, problem number one, how to reach those people who are not knowing their diagnosis and how to test timely. And that's why we were looking for new strategies, how to reach people, yeah, with the testing services. So yeah, the Hermetic project, it's European Commission funded project, and we had just quickly 3 work packages. The first one was the mathematical modeling, so to estimate the undiagnosed part, and which was approximately 1/2, as I said. And yeah, here I'm representing you the results, or presenting the results of the second work package, which is the experimenting with new testing strategies. And we chose, we have in Latvia pretty developed system of rapid testing of capillary blood. We have around 20 harm reduction sites, low threshold centers all around the country, which are using rapid tests from just capillary blood from, I don't know, 90s. But we have never used oral fluid tests. So that's why we decided to use them for this project. And yeah, work package 3 is just put together how to use the modeling data in the real life. And so my abstract was late breakers abstract because the data collection ended very recently. So we had 2 samples. Like one sample consisted of more than 300 people who are injecting drugs. So we were recently we opened one new mobile van service. So we did the mapping, to know where to go with this mobile van, how to reach new drug injectors. And also we were using testing, the stationary testing point. And we had more than 200 men having sex with men. And yeah, the idea was that, so we have the outreach work in nightclubs, but sometimes people are rejecting the capillary test because if they are at, coming to nightclubs, who does want to take the stuff with the blood, and that's why we were thinking that maybe the oral fluid test is more convenient for that kind of sites. And just shortly about the results. So speaking about the validity and performance, here you can see all the sensitivities, specificities, positive and negative predictive values, and and we were comparing ORA. We were using ORA-quick tests and comparing them with the capillary blood tests. The tests were produced by Chill company. And the reference is whether they are having positive capillary blood test from another company, or they are reporting, or we are knowing that they are previously HIV positive. And the conclusion is that accuracy, of course, is very high.
I'm sorry,
and
I have to ask you to.
And we didn't find any statistically significant differences between these populations. Like, the test was accurate among both of the groups. And the last slide, speaking about the acceptability, we used a questionnaire, actually mixed method, and also like the quantitative questionnaire and also the qualitative interviews and focus groups. And just 2 questions. Do you trust the result of oral fluid test, and would you recommend this test? And our conclusion was that actually the acceptability was higher statistically significantly among MSM and a bit lower among people who inject drugs, but still, as you can see from the numbers, it's very high. Thank you.
So I now just want to open up the conversation and the Q&A. So please, if you want to come to some microphones, we'll take maybe a couple of questions now. And just as a reminder, please do say your name and then your organization. Okay. Is that a question there? Sorry, okay, great. Someone's coming, great.
Hi there. Ronnie Lovett from the Education Development Center. I'm just curious if any of the speakers were in a position to assess mental health outcomes and whether there was any like severe depression or suicidal ideation. Is it possible to monitor and know how that might have compared to other testing?
So in our survey we include a measure on mental health, but we haven't looked at it yet.
Okay.
But we did. It is something we were aiming to look at.
Something to look at, yeah.
Sorry.
Okay, if I say something briefly for the setting in Zambia, so there was measurement of social harms, and it was relatively rare. I don't know the exact numbers, but it was low. There was no formal measurement about mental health.
Yes.
For us, we didn't do it for that study, but we're doing it now, and it's so high, we are shocked. In a community right now, it's really, really high, all the different measurements, but not in this study.
We performed in France an online survey on HIV self-test in MSM, and there's no published result, but we asked Christian about depression, mental health trouble, and we found that a lot of MSM report mental health trouble, but they tend to be less interesting in HIV self-test, and they are tending that they use less likely HIV self-test, but it's not significant. It's just a trend.
We have maybe at microphone 3, and then we'll come to the front.
I have 2 questions. Is that okay?
Can we
Just
take
one?
them both?
Yeah,
and then
sure.
maybe we'll take this one and the last one, and then we'll just do them all together.
Okay. The first question was for the last presenter, so thank you for your talk. I guess maybe I have a slightly different interpretation of your result. I think an 80% sensitivity perhaps I wouldn't consider accurate. I guess when you put sensitive and specificity together, maybe so. And I just wondered, I know you had a very short time to talk, but whether you were able to tell us a bit more about the positives. Were they acute infections or established infections? What do you know about the samples to explain perhaps that sensitivity of 80%? So that was my first question. The second question was for the presentation from Malawi, and amazing presentation. I've heard it before, and it was really impressive to see that work. The question was about social harms. I guess a number of the presentations at the conference have talked about social harms for self-testing. But I sort of feel that social harms can occur for all types of testing, whether it's self-testing, whether it's facility-based testing, and I don't think we should minimise them in any way. But I wondered in Malawi, do you have any data that you could perhaps talk about with the expected social harm rates for facility-based testing to compare to put the social harms in perspective for self-testing?
Excellent. So just before we respond, we'll just collect these ones over here. So over here.
Okay. My question is for the next to the last speaker, Mark Page. My name's Tonya Petit from Johns Hopkins. And we've been doing, we have a longitudinal study running with transgender women, and we've been offering self-testing, and people have been refusing it. So I was very interested in the fact that people were very excited about having a friend come. And then you mentioned that you had follow-ups a year later, and I was wondering if you could talk a little bit about what the intervention was over the course of the year, and a little bit more about what it was about having the friend that made the self-testing better or just made the experience better.
Great. And then we have one in the back as well.
Jim from China. I have two questions. One question is the self-testing regions used in your study is get approved from your country FDA? This is the first question. The second question for the last presenter. In your study, your result have high accuracy. So the self-testing in your study was conducted by the participants themselves or conducted with the help of peer educators or some health staff? Thank you.
Okay. Maybe we can start and just work our way up to the front.
Okay. So the first question was about who was the... Yeah, I wanted to mention that in my presentation that our testing was not self-testing. It was provided by harm reduction sites, so the participants are invited by peers or trained social workers, street workers, but the testing according to Latvian legislation is can be done only by medical staff. So this is a huge limitation. So that's why they the testing was done by nurses, trained nurses. This was about, so no, we are on the way of self-testing, but Latvia has such a high stigma against HIV that I'm not sure that we are ready for self-testing. We are on the way, but still way to go. This was the last question, and the first one about the accuracy. Like we were looking on the people with the non-fitting results. You know, one test positive and a capillary blood test negative or vice versa. And of course, we need to do more detailed analysis, but what we discovered is that half of the non-fitting results were among the people who are on ART, means they are using treatment for HIV, and then the saliva test might be negative or positive if we are comparing with the capillary blood test. So this might be the reason.
I'm going to try to answer your question. In regards to the intervention, what we did was that we followed the participants for a whole year. So every third month, we had them do a survey. And in the survey, there were an array of different questions that we asked them and that they would answer. Often the participants would come in and collect their the money that we were giving to them, the small incentive to get them to come in. So they would come in there, and what we would do then is provide them with a home test that they would take home with them. So that's how we got the test to them. As we followed them throughout that year, they would decide if they would let us know what their test results were, if they tested using the self-test, or if they went to some clinic or to a hospital or somewhere else and had a test done. And that's how we followed them that way. And I can't remember the rest of your question, but I hope I'm answering what you asked me to do. And so, yeah, so at the end, how we followed them, and then at the end, what we did was we had them come in for an exit interview. And if they wanted another testing, we would give it to them. And if they wanted, and what we did was to enter into the study, I would perform a Lear test on them to make sure that they were indeed negative when they entered the study, so that we would follow them. And so at the end of the study, we would give them another test if they volunteer for another test.
I think just briefly, in Kenya, we don't follow FDA, we follow WHO. And so after WHO pre-qualification, Kenya went ahead and developed guidelines. And right now, as we speak, it's being rolled out. Self-testing is being rolled out in the general community.
I had a question about social harms. So the three I presented in my presentation, they weren't specific to self-testing, so they were all a product of discordant couples results and disputes within those specific couples. I think and none of the none of the cases that we saw through our community-based social harms monitoring system detected cases that are more specific to self-testing, so coercive testing or coercive disclosure. We tried to track those through our household survey, and I think it was around like 2 or 3% reported coercive testing. But I think in past studies, they've found that it kind of comes at the expense of, I guess, people being okay with somewhat pressured to test. But in terms of comparison by arm, for incidence of prevalence of social harms related to testing is one thing where an analysis that we're trying to do, and trying to do a mixed methods analysis around that using our household surveys and our qualitative research.
Excellent. I just wanted to take a moment on to the last speaker, this issue about retesting on ART or testing with any serology is something that's come up, I think, in previous research. Current WHO guidelines state with any testing, people on ART should not test with serology. So I think it's an important thing for us to reflect on as a self-testing kind of community of researchers, that there's an important piece of, if you're trying to talk about accuracy, it's important to either exclude those folks or to provide analyses that separate that out, because it will really kind of impact your results. And I would really say that those tests are not designed for that intended use. So it's an important thing in each of the manufacturer's instructions for use that have CE mark or FDA or WHO pre-qualification, that they actually state this test is not to be used with people on ARV drugs for prevention or for treatment. So I think that's an important thing.
Little remark. I did both analyses. One with by excluding the people we know, which were known previously to be positive, and there was like not many of them, and the result of like and we were reading. There are a couple of articles comparing oral fluid test with capillary test. We have some peer-reviewed articles so far, and but the result didn't change too much. It was the statistical significance or any differences were pretty much the same. If we are excluding them. But you're right, of course.
No, I just think that's maybe an important thing to be raising in this conversation. Sure. I also wanted to ask you, just in terms of your capillary, what your reference standard was. You mean what did you compare the oral test to? To which brand name test?
CHEIL. It's 4 letters.
Okay.
CHEIL. I think it's from Turkey. Colleagues, maybe you can help me. CHEIL. It is written like this. So we are using this on daily basis, these tests, for years.
So it was a single test compared to a single test?
Yeah.
Okay. Thank you for clarifying. I think we have just a few minutes. Maybe, we can take this question.
Hi, George Rutherford from the University of California, San Francisco in the U.S. For those of you who distributed tests, did you see any secondary market? Did you see them being sold? Is there any kind of perception of value in the community?
What I found interesting is that I would ask I did ask a couple of them what they were going to do with the test if I felt as if they were not going to might not use the test. I wasn't sure at times, but then they were guaranteeing me that they were going to use it. I have not seen anyone selling the test. What is interesting to me is that some of them would keep the test and maybe end up with 2 at the same time, and so they would tell me that they had enough and they will wait until they had run out of. But so far, I haven't noticed anything of that. I'm not sure if the PIs have found anything yet in the studies, but they tell me no, they haven't. So they haven't.
That's like the test is the stock market going down. That's the real test.
There's a study that's doing buyback. It's like if you don't use, we'll buy it back from you to kind of discourage them selling to somebody else, so that at least that addresses that, but it's not our study. I like that.
So I just want to thank everyone for coming to this really important session and just provide a few kind of closing remarks. I think this has been a really excellent panel. What's been so nice is to actually hear a lot of global experiences. Following the WHO guidelines in 2016, we've seen a tremendous uptake of countries taking self-testing forward. And I think this is one of the first sessions I've been in of really seeing countries go beyond a traditional trial design and into real more implementation. And I think that's been a really great thing to see. Some of my key takeaways are really couples and partners. I think that I'm really encouraged, Kawango's results as well as Mark's results, really thinking about, one, couples and partners. Can we use and leverage self-testing to actually achieve our couples and partners testing goals? We know there's a strong preventative effect. We can really be doing more. Is that something we can leverage? There's been a lot in this conference as well about index or partner notification. And so I think that's a really interesting place to think about self-testing more broadly. I'm also really intrigued by buddy testing. I mean, to me, that was such a really compelling idea, particularly for adolescents and young people, to be thinking they will want support and wanting to test. Can we find models that will work well to increase their uptake and also provide the support they need? And I think that's a really interesting thing that I've taken away. I've also took away from France today the pharmacy-based approach. I think a lot of countries are thinking about pharmacies, but we're learning pharmacists might need more to be equipped to feel comfortable. What is that training? What is that information? So if we are trying to think about collaboration with the private sector, what types of information do pharmacists need? And I think there's an issue you touched on in the poster and in the presentation of in front of the counter and behind the counter. And I think we don't really talk about that too much. And how that really impacts the user preferences. So I think as a collective group, it's really important if we want people to access self-testing in the pharmacy, it has to be positioned in a way that's really accessible. Behind the counter probably isn't going to really help people access the kit. And where it's positioned in the store is maybe something to explore further. And then I think coming from our colleagues with the community-based distribution models, I think it's actually encouraging to see some results telling us that the linkage to care should not discourage us. I was really encouraged that we didn't see undermined linkage to care, and that's long been a question on self-testing. And I think as a group, it would be really good to help disseminate that further. And then lastly, I would just say to the last discussion, there needs to be a lot more community messaging about this. People who know their status and who are on treatment should not be retesting. And I think that this is an issue that's come up in a number of dialogues we've had in the Global Village or in conference presentations, that this is not a message our community really knows. There's a lot of concern, and I've even had networks of people with HIV say, I wanted to show people how to use a self-test because I'm really passionate about it, but then it came out negative. And then everybody was confused. And so I think that we really need to be doing a much better job of getting that message out there. And also saying this is not a self-testing issue. This is an issue that's come up. Retesting is happening more and more. As we get closer to the first 90, it's finding people who don't know their status is more challenging. So we are seeing more retesting. And I think that some messages like, think about if you want to know how your treatment's working, maybe you should get a viral load test, or there may be some other more perfectly crafted messages from communities themselves of how we can do a better job with that. But I just want to thank everyone for coming and say, can we give a round of applause to our amazing presenters?